Good day. I'm Dr. Wayne Jonas, a family physician and expert in integrative health, and I'd like to talk to you today about how to implement it in your own practice, in your education, and have tools available for delivering it in healthcare. I'm fortunate to have had a long career both in practice in the military, as a professor of family medicine at several universities, and also to have run research organizations, including the Office of Alternative Medicine at the NIH, teaching research at Walter Reed Army Institute of Research, and then for 15 years as director of the Samueli Institute, a research organization focused on the process of healing. Let me talk now with you about the importance of integrative health in the future of healthcare. Right now, there's a lot of debate on healthcare reform in the United States, and the discussion is mostly about who's going to pay for the healthcare we currently have. Will it be the employer? Will it be the government? Will it be you? But this is the wrong question. We should be asking not who will pay for current healthcare, but how do we get from healthcare to health and well-being? This is where integrative medicine is important. Let me illustrate this to you with a couple patients of mine to show you what this looks like. I'll start off with Sally. Sally was an executive vice president who worked for the military. She had what I call platinum level health care. She had a car accident and developed some low back pain. It persisted. She was put on non-steroidal anti-inflammatories, sent to physical therapy, and it improved somewhat, but didn't go away. Eventually, she developed chronic low back pain, a common problem in our country and around the world. She then began to have x-rays, CT scans, and was sent for further therapy. Several months later, she was lifting a suitcase and she felt excruciating pain in her back. She went back in for more tests. She did not have a procedure that required surgery. She had functional back pain, which is by far the most common, and so they gave her opioids. She liked the opioids because they helped with the pain and they allowed her to maintain her very busy schedule. However, like many people who start on those drugs, she became addicted and she needed to increase the amount of opioids over time, developing opioid tolerance. She eventually was sent to behavioral medicine, in which she was given further drugs and more diagnosis, depression, and eventually told she should go into rehab, which she refused to do. As she said to me the first time I saw her, "Doctor, I'm not crazy and I'm not addicted, I'm in pain." Sally, because she had good health care available, had many visits. And when she went to see her practitioners, they routinely applied what's called the SOAP note. This stands for Subjective Objective Assessment and Plan. Subjective, what she tells you. Objective, what you observe and what tests show. Assessment, the diagnosis with a CPT code, and the plan, the evidence-based treatment to try to do that. The SOAP note asks the patient, what's the matter? Its goal is to come up with a medical diagnosis and a treatment plan. But this approach is limited for patients like Sally, and as I'll show you, needs to be expanded with other tools. Sally's team over the years, and I put team in quotes, consisted of her primary care physician, a physical therapist, pain specialist, a surgeon, behavioral medicine pharmacologist, and many others. They were not really a team. They weren't working together. Each of them individually saw Sally and made their own recommendations, and often those recommendations contradicted each other or were hard to coordinate. Sally, unfortunately, is not alone. In our country, the United States, opioid prescriptions have increased dramatically over the last decade, resulting in opioid deaths topping 60,000 and almost 12 million Americans who are misusing opioids, that is, using them when they should not be, in cases like Sally. This is costing us billions of dollars and untold suffering. Guidelines coming out from groups like the American College of Pharmacology, the Food and Drug Administration, the NIH, and others have recommended non-pharmacological approaches to pain be used instead of drugs like opioids. The DoD and the Veterans Administration are now implementing these across the board. Had we been listening to patients for the last 30 years, we would have realized that many patients in chronic pain are already undergoing many of these non-pharmacological approaches. We just called them complementary and alternative or integrative medicine. They included things like therapeutic massage, yoga, acupuncture, spinal manipulation, and mind-body practices. These practices now have sufficient evidence so that national guidelines recommend that they be used for chronic pain, both first line and on a continuing basis. However, we have a dilemma. And the dilemma is that our culture, my practice, the payment systems, and even the patients have not been educated about how to implement these types of non-pharmacological approaches. I was not trained in them in medical school. Patients usually don't ask for them, even though they might be using them separately, and our system does not pay or reimburse for them. And so we need to change this dialogue. We need to change this if we're going to actually implement current guidelines for chronic pain. I do this with something called the Hope Note. After I know the diagnosis and the standard treatment through the SOAP Note, I do an interview with patients focused on their healing-oriented practices and environments. It asks what matters to you, and it begins by putting the patient in the center, person-centered care, and then fleshing out the underlying root causes, or what are known as the determinants of health. It asks questions about the spiritual and mental components of the person, about their social and emotional environment, about their behavior and lifestyle, and then about their body and the external environment. Let me illustrate how this happened with Sally. When I did an integrative health visit using the Hope Note tools for Sally, here's what emerged. First of all, she said medication management was a challenge, and this is a common thing in patients with chronic disease. Which medication should I use? She often was getting contradictory recommendations. Fortunately, on our team, in our family medicine primary care team, we have a pharmacologist, and I work closely with her to help organize that. Sally, we can help you with that. But what I wanted to know from Sally was not just what she did medically, but what did she do personally to try to improve her health. She told me that she'd figured it out over the years, that heat and stretching improved her health, so she had purchased a hot tub, and in the morning she would get her cup of coffee, get in the hot tub, and stretch and stretch and stretch for about an hour. If she did that, she could get through about noon before she needed to begin to take her medications for pain. I asked about sleep, and it was poor. She woke up frequently during the night, taking medications, restless, and she was not rested in the morning. I asked her about stress, and she didn't think she was under any stress. She wasn't working anymore because of her back pain, and she felt like her busy schedule when she was an executive was gone, and therefore she didn't need to relax. When I asked her how she relaxed, she said in the evening she turned on the TV and took a couple drinks. Not a good idea for chronic pain. So she needed stress management. And I explained to her that stress increases cortisol levels, inflammation in the body, and lack of sleep can all perpetuate chronic pain. So we needed to somehow address these. When we explored with her if she had a place and a time to engage in self-care, she couldn't think of that. Now, Sally was engaging in a sort of a form of yoga, if you will, the heat and the stretching, but she had gone to a yoga studio and attempted to do what was being done by the woman at the front, but that she hurt herself. Sally had not done good evidence-based yoga specifically designed for back pain, so she needed that information and instruction and needed to access somebody properly qualified and trained in that. But even if she did that, she didn't have a place to heal. I asked about her bedroom. She said it was a mess and the kids were coming in and out all the time. Things need to be picked up and fixed. She had no place to heal, so we needed a place where she could engage in self-care. But when I asked her what was the most important thing for her into her life, she started to cry and said, I knew that my back had doomed me when my family started calling me Sally again. And I said, well, what do you mean by that? Isn't that your name? And she said, yeah, but they used to call me Salary. I was the one who brought home the bacon. I was the breadwinner for the family, and I loved it. But now I can't do that, and it's all because of my back. Sally had lost her purpose, the mental and the spiritual reason for getting up and functioning during the day. Now with this integrative health interview, we had an idea of how to put her healing team together, and this is what that looked like. It consisted of me, her physician, but I was more orchestrating the team rather than providing specific pills and procedures for her. It involved the pharmacologist to help her manage her medication. It involved a behaviorist, not to diagnose her with a mental health condition, although counseling would have helped her, but to help her as a health coach and support her own self-care as she went through her healing journey. All of these things we have in our clinic, and we provided those things for Sally. What we didn't have and had to find is a properly trained yoga therapist who could deal with evidence-based treatments for her back and teach her the yoga approaches that could help with her back. So we had to go out and find that and find out how she could get it paid for. We needed her family on board because they needed to support her in her healing journey, including a time and a place to heal. We needed her body on board, or more specifically, we needed her mind about her body on board. She had to be able to see that her body could heal, that it was not, in fact, the enemy of her life. So once we got this team together, Sally went out and engaged with the yoga therapist, and she called me up after her first visit and said, you know, Doc, my pain level is down to 2. It hasn't been down to 2 outside of the hot tub for almost 5 years. She was not cured, but she was on her healing journey, and she had now been empowered to be able to care for herself, and she had some of the tools to do it. After 3 or 4 months of support through therapeutic yoga, her pain was regularly down to 2, and after another 3 to 4 months, she now said, I think I'm well enough to go out and find a job, regaining her purpose. This type of healthcare is called integrative healthcare. It's a different way to go about managing chronic disease. It consists of the conventional types of care that I learned and you're learning in medical training, evidence-based complementary practices that I may not have learned, and most importantly, self-care. All of this is done together in a coordinated fashion within the context of the social environment in which an individual lives. Sometimes the social determinants are important, such as transportation, food, stress, environment, in order to be able to engage in integrative health. If we don't do this, if we simply stay in the conventional care that we provide now, we will continue to get what we have. And unfortunately, it's not a very pretty picture. We are first in spending in the United States over any other country. We're 37th, according to the WHO, in health outcomes. If the inflation rate of healthcare goes up and the costs go up, we may spend up to 25% of our gross national product by 2025, which is unsustainable. And because of the rising costs, there's growing health disparities, a difference between those who are able to get good health care and those who cannot. This is a report that has documented many of these challenges, and this is one of many that are now out there. This was done by the National Academy of Sciences, the Institute of Medicine formerly, in which they looked at outcomes and costs over 30 years among the rich countries of the world. And what they showed that the United States is falling behind compared to most of those countries in many, many outcomes. And here's a list of a few of them. Most alarming is that the value that we're getting from the investment in healthcare is declining. We spend almost twice as much as any other country on healthcare, and yet if you look at our life expectancy, as this graph shows, we're somewhere around Portugal or Czechoslovakia or Cuba. Clearly, we're not getting value for what we do normally in healthcare. The reason for this is also clear. We know that if everyone had platinum level health care coverage like Sally had, this would only improve the population's health by about 15 to 20%. And that's because medical treatment, what I and you are trained in, only provides about that much health. The rest comes from 3 other major areas, and the 2 most important ones are behavioral and lifestyle approaches and the social and economic impacts of health, these so-called social determinants of health. Therefore, if healthcare wants to be part of the solution and not the problem for producing health in the country, we need to get out of the top circle here and begin to go into the underlying determinants of health. Let me illustrate how this happens in another patient of mine that you may recognize with similar chronic illnesses. I'll call him Joe. He was a 69-year-old Navy veteran, and he came to me after he had been hospitalized with a heart attack, a myocardial infarction, for his rehab and preventative care. Here's his history. His father had an MI at 65, and then he died of heart disease at 75. That's when Joe stopped smoking. He was 35 at the time. Later, Joe developed hypertension. Then he gained weight after he left the Navy and became obese. This was followed by type 2 diabetes at 55. Now, this typical story for Joe occurred within the context of good medical care. He had access to medications, to specialists, to veteran care, to DoD care. He had full benefits. Joe had been the food guy in the Navy. He had started off on small PT boats, peeling potatoes and making food from scratch for about 15 people. And then he had graduated to aircraft carriers and eventually providing food for entire bases, and then as an advisor to the entire Navy on food. And over that almost 40 years of his career, he had seen food preparation go from the scratch, fruits and vegetables, peeling potatoes, to what he called industrialized food. Now, on the outside, they called this fast food, and many of his service members were also eating this way and liked it. When he was told later on to go back to more fresh fruits and vegetables, peeling potatoes, he found that if he put that in his mess hall, many of the service members didn't like it, and they would go down to the local fast food shop, and he would lose his budget in his mess hall. So it became a challenge to be able to go back. When I first saw him after his heart attack, he said, "Doc, you know, I ate this way too. And I know this has something to do with how I got into the situation of my heart disease. Can you help me with that?" Here's the different diagnoses that Joe had received through his SOAP notes over the years. Hypertension, he was on 2 medications for that. Elevated cholesterol, 1 medication for that. Diabetes, another medication for that. When he was told he had obesity and was sent to the dietitian, he said, "I know more about food than she does," and he only made 1 visit and never went back. He was now post-myocardial infarction. He'd had a stent placed, which probably saved his life, and he was on a beta blocker, another drug. He was told to go to cardiac rehabilitation, which basically involves supervised exercise, but Joe hated exercise. He liked food, but he really didn't like that part of his rehab. When Joe came in to see me for an integrative health visit, I engaged him in the Hope Note process, and I asked him what mattered. As many patients start off with, he started talking about helping to manage his medications. He was on lots of them, and they were being switched up. I said, "Joe, we can help you with that. We have a pharmacologist, and I will work with you to help you get that sorted out and organized." But then when we got it to what he really wanted out of his health care, What he wanted to do was prevent further disease. He'd seen his father suffer from a heart attack and then die at 75. He was 69, and he didn't want to die in another 6 years because he had a lot to live for with grandkids and other things. How can you prevent that is the question that he asked me. And this was his primary interest. He knew that fitness and food had something to do with it, but he didn't like fitness. He didn't like the exercise, but he liked the food. He knew he had to make some changes. His typical routine was to go to the club in the evening with his friends, order a hamburger, fries, and a couple drinks, and talk with them about all their medical visits. He knew he had to change this situation, so he had to have his family and friends on board for support. But what was most important to Joe is that after he had retired, he felt like he wasn't really contributing to society. All his career, he was doing something important for the country, for the Navy, for his community, and for his family. And now he felt like he wasn't as valuable. He had lost his purpose. He needed to figure out how to regain that. This allowed us to construct for Joe and with Joe his integrative health team. Included myself, who helped to organize it and help manage his medical conditions. It included the pharmacologist to help him with the medication. It included the nutritionist, but now the nutritionist had to ask not as somebody who was going to tell him what to do, but to support him through that. And to do that, we needed a health coach, and we needed someone to help him know how to cook it, which he was pretty good at. Fortunately, there was a program on the Post called Healthy Kitchens, Healthy Lives. It was a 12-week program for people with heart disease in which the nutritionist showed how to pick nutritional, healthy foods. The chef showed you how to put them together, and the health coach showed you how to make them part of your regular life. I figured Joe would like that, and so he signed up. We got his family and his friends on board for his healing journey, and we got his mind oriented in the way of improved prevention and self-care. Joe went to the course, and in 12 weeks he lost 5 pounds. He was feeling better, but he asked me, why is this only available for people with heart disease? I needed this 30 years ago. And I said to Joe, that's exactly right. Why don't you help start something like that? A light went off in Joe's eyes, and suddenly he realized what his next purpose was going to be. He started an ongoing program and opened it up to others, not just those with heart disease. He became the coordinator, he became the chef, which he loved, and he taught others how to eat healthily and engage in healthy behavior change. He'd regained his purpose. I saw him about a year after that, and he'd lost 60 pounds. He was off all except one of his hypertension medications. His diabetes had gone away. He felt better, but he said to me, I had a side effect. I said, well, what was that, Joe? He said, my heartburn went away. I said, your heartburn went away? I didn't know you had heartburn. He said, well, I didn't think it was important to tell anybody about, but it doesn't matter. It's gone now. This is a new type of healthcare. It focuses on empowering and supporting self-care. It integrates evidence-based, conventional, complementary, and lifestyle approaches, and the evidence shows when patients get engaged in managing their own health care, outcomes improve and costs go down. The question I'm often asked is, can we do this in our current system? And my answer is yes, we can. Here's an example of students that I teach in medical school learning something called battlefield acupuncture. This uses little studs in the ears that help treat pain. So it's a non-pharmacological approach to pain. All the medical students at the Uniformed Services University come out trained in this, and the military has now trained 6,000 providers in this particular technique. In addition, the military has implemented what's called the performance triad for the healthcare system. This includes nutrition, activity, and sleep, 3 core salutogenic or health-promoting factors now being delivered by the medical system. The Veterans Administration has gone one step further, in fact, creating a new paradigm shift in how healthcare is delivered with a program called Whole Health. They now have 18 centers of excellence up and running that focuses on what matters to the patient. The patient sets the goals, that's person-centered, and the healthcare team develops a relationship to support them in achieving those goals. The preliminary data from this shows not only improved outcomes and better satisfaction, but lower burnout among providers and significant cost savings per veteran. Here's their model. First, to empower the patient by asking them what matters to them in their life and making sure their healthcare supports that process. Second, equip them with the knowledge and the tools necessary for self-care. And finally, integrating that with the medical treatment that they have. And that's where medical professionals like us come into play. They do it through tools such as the personal health inventory that I'll show you in just a minute, and the development of a personal health plan. Often outside of a government organization like the military or the Veterans Administration, I'm asked, but how do we pay for this? My answer is we're already paying for it, and we're already paying too much. 5% of patients currently account for 50% or more of healthcare costs. These are folks at the top of the pyramid with advanced illness. We're developing approaches to help manage those costs, but what about the other 95% in the pyramid underneath? Those who are at risk, those who have chronic illnesses, and those who are healthy but may develop those if preventive and lifestyle are not changed. We need a system that addresses both the top 5% as well as the lower 5%. Integrated care, systems of care that focus on care coordination, now address the top 5%. They help prevent hospital readmissions and emergency room visits. They are expanded primary care, reduction of drugs, specialist care, labs, and imaging. We also need an integrative health system, and that's what I'm proposing here in this talk for the other 95% that focuses on health promotion, lifestyle as both prevention and treatment, involving health coaches, integrative health practices, and addressing labs, imaging, and supplements. In policy areas, we have a term for this. It's called value-based care. And paying for value rather than volume, just doing more of the same, is where we need to go. And payment models are now beginning to go in this direction, and some practices now have their toe or their foot in the value-based reimbursement boat. Unfortunately, most people are still standing on the fee-for-service volume-based dock, and I can tell you the boat is leaving the dock. We need to get fully in the value-based boat or we're going to fall in the lake. So what can you do in this area? You don't have to wait for policy to change. You can begin to do this every day in your own practice. First, continue your standard of care. Do what you're already have been trained for, and provide. Then add an integrative health visit using the personal health inventory and the Hope Note. This reframes the questions and the goals to get at what matters and the underlying determinants of your patient's health. Add some simple techniques such as ear acupuncture, mind-body practices, nutrition, and safe supplements when the evidence warrants it. Bring in advanced healing technologies such as heart rate variability, biofeedback, cranial electrical devices, behavioral apps, and telehealth. These are advancing rapidly and are useful tools for enhancing self-care. Finally, look at redesigning your team. Incorporate health coach training, team care, group visits, and shared decision-making so that the person is in the center of the care and everyone's practicing at the top of their training and license. This reduces burnout in providers and is highly satisfactory. Talk to your patients about what they can do. Again, focus on helping them develop their own personalized healthcare plan. First, find your meaning. What's important in life? You can do this through the personal health inventory to ask them to write down what matters to them, what brings them happiness and joy, why do they get up in the morning, and have a talk about that. Do an integrative health visit or ask them to do an integrative health visit to explore how health impacts their life. And then out of that, have them be part of developing their own personal health plan, communicating to you about complementary and alternative providers and other things they're using to integrate with the standard care that you provide. Here's an example of a tool I've used in practice that can rapidly change this conversation and is an excellent tool for starting an integrative health visit. It's called the Personal Health Inventory. It asks the patient what matters in their life. Why do they want to be healthy? Ask them then where their health is right now and what are the underlying factors that they feel like they need to work on and what are they ready to work on in those areas. They can fill it out in 5 minutes and it changes the conversation within the visit rapidly. I then do what I call an integrative health visit using the Hope Note tools. Here's an example of some of those tools. They ask about the spiritual and the mental components, the social and emotional aspects. Everybody has a social and emotional body and needs social support. It asks about their behavior and lifestyle, and there's a set of core issues such as diet, sleep, stress, and activity levels that everyone needs to have addressed. It asks about their physical environment, the body, and the external components. This process is being implemented now around the country in large networks and hospital systems, but you can do it in your practice on your own. If you go to my website, I have a Hope Note toolkit that shows you exactly how to implement integrative health. It tells you how to prepare you and your patients for it and your team to actually engage in an integrative visit, and then how to provide the support, like you've seen with Sally and Joe, to help them start and remain on their healing journey. If you go to my website, I'm in the fortunate position to being funded by the Samueli Foundation, a nonprofit public charity, to make these tools available. I've gathered these tools from around the country, from practices all over the world, in fact, and are now condensing them to make them easy to deliver. So there's no excuse to not start doing this on Monday. Integrative health is the future of healthcare. It's just simply good healthcare. So go ahead and begin and make it an integral part of your training and your practice. Thank you very much.